The chest is open. The heart is not beating. A machine is doing both jobs, circulating blood and delivering oxygen, while the surgeon works on a field that is completely still. You are a third-year medical student. Your job is to hold a small suction tube out of the way and not touch anything. The surgeon's hands move without hesitation. A tiny vessel on the surface of the heart, one of the arteries that feeds the heart muscle, has been blocked. The surgeon is building a bypass, a new route for blood constructed from a vein taken from the patient's own leg. The connection takes 18 minutes to sew. It is smaller than a pencil tip. It has to be perfect. The connection is finished. The bypass is tested. Blood moves through the new vessel. The machine slows. The heart is asked to restart. It does. You don't move. You don't say anything. You stand there and watch the thing you will spend the rest of your life trying to do. You don't know yet what this room will take from you. Not the years. Not the debt. The night you will write 2 operative notes and only one of them will describe a patient who survived. Rank 1, the medical student. Cardiac surgery rotation week 1. You show up at 5:45 a.m. because someone told you that's what you do. You don't fully understand why yet. The surgical ward is already moving. The patients on the list for today haven't eaten since midnight. Several of them are afraid. You can see it. Nobody has time to sit with them about it, so nobody does. The first case is a 58-year-old man. 3 of the arteries that carry blood to his heart muscle are critically narrowed. So narrowed that the heart isn't getting enough blood to function properly. He had a small tube called a stent placed inside one of those arteries 2 years ago to prop it open. The stent failed. This is what comes next when that happens. The operation is called a coronary artery bypass graft. The surgeon builds detour routes around each blocked artery using blood vessels taken from the patient's own body. One from the leg, one from inside the chest wall. To do this safely, the heart has to be stopped entirely. A heart-lung machine takes over. It pumps the blood and adds oxygen while the surgeon works on a heart that isn't moving. The whole thing takes 5 hours. Your job for 90 minutes of it is to hold a suction tube in a fixed position. Then you are told to step back. You step back. The following week, a valve replacement. A woman in her late 60s. The valve between her heart's main pumping chamber and the rest of her body has been slowly hardening for decades. Calcium has built up on it the way scale builds up inside a pipe until the opening is barely the width of a pencil. Her heart has been compensating, working harder and harder for years, and it is starting to fail. The surgeon removes the damaged valve and saws in a replacement made from animal tissue. Before the chest is closed, the team tests it. You hear the new valve click. You will not forget that sound. On rounds one afternoon, you see something you don't have a framework for yet. 2 patients. Nearly identical diagnoses. Nearly the same age. One has private insurance. One is on Medicaid, the government program for lower-income patients. They are offered different operations. The Medicaid patient's procedure is less invasive, faster to recover from, and carries less surgical risk. It also wears out faster. It will probably need to be redone in 8 to 12 years. The other patient's operation is more complex and is designed to last a lifetime. Nobody explains the difference to you. You don't ask. That night you look it up. You find studies going back 15 years showing that this gap, more intensive procedures for patients with better insurance, is documented across hospitals, across regions, across the country. It is not a secret. It is simply present. You don't know what to do with it. You file it. The rotation ends. You are 24 years old. The path from here to operating on a heart alone runs through 4 more years of medical school, at least 6 years of surgical residency, and 1 to 3 years of advanced specialty training after that. 13 years minimum. Roughly 1 in 200 people who start this path will finish it as fully certified cardiac surgeons. You know this. It doesn't change anything. There is someone you have been with for 2 years. That relationship is already running on what is left over after the hours. You note this the way you note a number that is trending in the wrong direction. Something to watch. Something you will address when there is time. There is not yet time. Medical school ends. Intern year begins. Rank 2, the intern. Your salary is $63,000 a year. You work 80 hours a week. That comes out to about $15 an hour. Some weeks it is less. The cardiac ICU has 14 beds. Every patient in it has had their chest surgically opened within the last 72 hours. Your job is not the operating room. Your job is what happens after the operating room, keeping the patient alive while the body figures out how to work again after everything it just went through. At 2:40 a.m., 11 days into intern year, a number moves the wrong way. A 72-year-old man, 1 day out of bypass surgery, has oxygen levels in his blood that are falling, which means his heart, the one that was just repaired, is not pumping well enough to sustain him. This is called low cardiac output syndrome. The heart stunned by the surgery can't fully recover. It happens. It is the most common reason a post-surgery patient deteriorates overnight. You adjust the medications that help maintain his blood pressure. You call the senior resident. You call the attending physician. You follow every step in the protocol. Every decision you make is the correct one. The patient dies at 5:40 a.m. You write the death note. It takes 11 minutes. You document the timeline, every intervention, every response, the time of death. You close the chart. You walk to the next room. The patient there is recovering normally. You check the tube draining fluid from her chest. It is within the expected range. You note it and move on. Later, reviewing the first man's file, you find something that stays with you. Before his surgery, a scoring system that factors in his age, heart function, kidney health, and other variables estimated his chance of dying within 30 days of the operation at 19%, nearly 1 in 5. The surgery was performed anyway. The risk was written on the consent form. He signed it. The surgeon reviewed the numbers and decided to proceed. This happens every day in cardiac surgery. By every formal standard, it was a legitimate decision. You don't know if it was the right one. You are not in a position to ask. That question sits in the same place as the insurance gap you noticed 3 months ago. Not answered, not dismissed, just there. Something you are carrying at a rank that doesn't yet give you anywhere to put it. Intern year ends. You are 27 years old. You have $295,000 in debt. You have written 1 death note. The question about the man with the 19% risk score is exactly where you left it. Rank 3, the junior resident. Year 2. Your first assigned operative task is not a bypass graft. It is not a valve. It is harvesting a vein from the patient's leg, removing a segment of blood vessel that will be used to build the detour routes once the chest is open. The attending watches your first incision, then leaves to open the chest. You are alone with the leg. The vein runs from the inner ankle to the upper thigh. If you tear one instead of clipping it, the vein bleeds. A damaged vein segment may not be usable. A faulty detour graft placed near the heart can fail. This is the foundation the rest of the operation is built on. On the third case, you tear a branch. Small. You clip it immediately. You inspect the vein on both sides of the tear. The wall is intact. The attending is at the other end of the table and does not see it. You say nothing. That night, you look up the hospital's incident reporting requirements. A small branch tear that is identified and repaired on the spot, with an intact final graft, falls within the documented range of normal operative variation. No formal report is required. The patient's recovery is uncomplicated. The graft functions. The question doesn't fully leave. You're not sure what it would mean to report something that caused no harm, required no change in the patient's care, and falls within what the rules define as acceptable. But the rules and the right answer are not always the same thing. You file this alongside everything else you don't yet have the standing to act on. By the 8th harvest, the vein comes out clean in 36 minutes. The attending stops watching before you finish. That is the benchmark. Nobody says so. You understand it anyway. You also start doing the beginning and end of chest operations, making the incision, helping divide the sternum, and then closing everything back up at the end of the case. Closing means suturing through the dense connective tissue layer beneath the skin, the layer that holds the chest wall together under tension. It matters. And at the very end, before closure, you sew thin temporary wires directly onto the surface of the heart. If the heart's rhythm fails overnight in the ICU, those wires allow the team to pace it externally, to send an electrical signal from outside the body that tells the heart when to beat, without reopening the chest. Your first time placing them takes 14 minutes. The attending says the target is 4, the full operation and the shorter alternative, and you can see the difference from the inside. The full procedure is more technically demanding and built to last. The shorter one is faster and has a lower immediate risk. You have a more informed opinion now. You mention it to a fellow resident during a break. That's above your pay grade, they say. They are not wrong about the pay grade. They are not saying it isn't a real question. They are saying it belongs to someone else's rank. You understand the distinction. You also understand that whoever holds that rank has not raised it either. Year 3 ends. You are 29. You have $309,000 in debt. Your operative log. The running count of cardiac cases the certifying board requires you to accumulate during training shows 190. You need 250 more to meet the minimum for graduation. A child was born 4 months ago. You note this the way you note the case count. Something you will return to when there is time. There is not yet time. The cases get larger. Rank 4, the senior resident. Year 4. Your first full bypass operation as the primary surgeon, from the first incision to the final suture. The attending is scrubbed in beside you. Their hands are close to the field. They are not in it. Before the first incision, reviewing the patient's file, you find a test result that gives you pause. The test checks whether it is safe to harvest the artery from the patient's forearm, one of the possible vessels that can be used to build the bypass route. The way the test works: you press on both arteries at the wrist, have the patient open and close their hand until the skin goes pale. Then release one artery and watch how quickly the color returns. If it returns slowly, that artery may be the main blood supply to part of the hand. Taking it carries real risk. This patient's result is borderline. Color returned in 6 seconds. The standard threshold most programs use is 5. 1 second outside the margin. The attending on this case prefers using the forearm artery in patients with this particular vessel profile. You raise the test result before the operation starts. You explain what the number means and why it concerns you. The attending reviews it, considers it briefly, and disagrees. The forearm artery is harvested. The operation itself is technically clean. The bypass routes are built without any complications. The heart restarts on the first attempt. The chest is closed. The patient goes to the recovery unit in stable condition. 2 days later, the patient says 2 fingers on the hand where the artery was taken feel numb and cold. A vascular specialist, a surgeon who focuses specifically on blood vessels, is consulted. Their assessment: it will probably improve with time. It might not fully resolve. The attending's notes document that the borderline test result was reviewed and that the decision was made with the patient's informed agreement. This is accurate. Your preoperative concern is also documented in the chart. Also accurate. Neither of you discusses it directly afterward. The system functioned. The resident was right. Both are true. You have been in training long enough to understand that 2 true things can coexist in the same chart without producing an answer. The attending had legitimate authority. Your concern was correct. The consent was valid. The complication fell within the disclosed risk range. None of these facts cancel the others out, and none of them give the patient back the feeling in those 2 fingers. You go back to the operating room. Year 4 ends. You are 30. You have $318,000 in debt. Your case log shows 395 cardiac operations. You need 45 more to meet the minimum. Your child at home is 14 months old. You've been present for less of that than you planned, and more than some residents in your program. Rank 5, the chief resident. It is 1 a.m. and a patient in the cardiac recovery unit is dying in a way that cannot wait. She had a heart valve replaced earlier that day. Now blood is collecting in the space around her heart, the thin sac that surrounds it. A heart that cannot fill, cannot pump. Her blood pressure has been falling for 40 minutes. Her neck veins are visibly distended because the blood that should be flowing into the heart has nowhere to go. This is called cardiac tamponade. The attending is 20 minutes away. You are the most senior surgeon in the building. You remove a dark clot that has been pressing directly against the right side of her heart. The compression releases. Her blood pressure begins to recover before the attending's car reaches the parking structure. She goes to the operating room later for a proper surgical closure. She survives. She goes home 8 days later. The attending arrives, looks at what you have done, and nods once. That's it. No speech, no ceremony. One nod. Then the quieter kind of power. At the end of year 6, you submit formal performance evaluations on every resident below you in the program. One of them is the junior resident, the same one who raised the insurance disparity and was told it was above his pay grade. He is technically strong. His surgical numbers are among the best in his cohort. But twice this year he raised concerns in case reviews that created friction with senior staff. He wasn't wrong either time. The concerns were legitimate. The timing and the room were wrong. The evaluation form includes a professionalism rating. A negative mark there does not disappear. It follows a resident through every job application, every fellowship interview for the rest of their career. You sit with the form for a long time. You write, technically strong, asks difficult questions, timing and delivery inconsistent with team environment. You do not mark professionalism negatively. You don't know if that was the right call. It was the honest one. After the bedside procedure, 40 minutes bent forward, arms extended, holding position, something announced itself in your neck and upper spine. Not sharp pain, pressure, deep and central. It was there when you drove home and still there when you woke up. You filed it the way you file everything that is inconvenient and not yet urgent. You haven't followed up. This year there was a school performance you didn't make it to. Your child was in it. You found out afterward from a photograph that was sent to your phone. You noted it the way you note a number outside the normal range. You did not decide what it meant. Year 6 ends. Fellowship matched. Residency over. You are 32. Debt. $322,000. You opened a chest alone in the middle of the night and kept someone alive. You also wrote an evaluation that will follow another person for 20 years. You are not sure which one required more from you. Rank 6. The attending cardiac surgeon. Fellowship ends. First attending position at an academic medical center. Your salary is $395,000. Malpractice insurance, the coverage every surgeon pays out of pocket in case a patient sues. Your name is on the operative report now. That means something different than it used to. In your 3rd month, a case is presented at the weekly conference where the full cardiac team reviews complex patients together. A 76-year-old woman. Her aortic valve, the valve between her heart's main pumping chamber and the rest of her body, is failing. Without surgery, she will likely deteriorate and die within 18 months. Her predicted surgical mortality is 11%. Her ability to understand and weigh what she is consenting to is severely diminished. A cardiologist argues she should not be offered surgery. The cognitive decline means she cannot meaningfully participate in the decision, and the quality of life benefit is uncertain at best. A surgical colleague agrees. There is a reasonable case for comfort-focused care only. You review the imaging. You speak with the family for 40 minutes. You read the advance directive, a legal document she completed 7 years ago, before the dementia progressed, stating her wishes for medical care. In it, in her own handwriting, she says she wants all available treatment pursued. You take the case. The operation is technically successful. The valve is replaced. The heart restarts on the first attempt. She is discharged to a rehabilitation facility 9 days later. Every surgical metric says this went well. 6 weeks later, she dies of aspiration pneumonia. During the night, fluid entered her lungs while she was sleeping, a complication of advanced dementia, completely unrelated to the surgery. Her heart valve is functioning perfectly. She died anyway. Her family sends you a letter. They say the surgery extended a period of suffering without extending meaningful life. They described the weeks she spent in a facility she didn't recognize, frightened in ways she couldn't articulate. They are not threatening a lawsuit. They are telling you what they saw. You read the letter. Then you read the advance directive again. The advance directive says, pursue all available treatment. The family's letter says, the treatment caused harm. Both are genuine. Both reflect something true about the same woman. They point in different directions. No legal claim is filed. No formal review is triggered. The operation was indicated. The consent was valid. The complication that killed her had nothing to do with your work. Nothing went wrong by any standard the institution tracks. You operate the next morning at 7:10 a.m. 3 months later, at 11:20 p.m., you are the only cardiac attending in the building. 2 calls come in within 6 minutes of each other. The first, an 8-year-old boy. The main artery leaving his heart, the aorta, has developed a tear in its inner wall. He has a genetic condition that made his blood vessel walls fragile. Without surgery in the next few minutes, he will die. His odds with surgery are not good, but without it, they are 0. The second, a 61-year-old man. He had bypass surgery 2 days ago. Now his heart, damaged and overwhelmed, is no longer pumping enough blood to keep his organs functioning. He is deteriorating. A second cardiac attending has been reached and is driving in. 22 minutes away. The 61-year-old's survival odds, if operated on immediately, are better than the boy's. He is not yet at the point of no return, but he is moving toward it. You cannot be in 2 operating rooms. You take the child. The tear in the boy's aorta is repaired. He survives. He spends 31 hours on a breathing machine in the pediatric recovery unit and then comes off it. He goes home 3 weeks later. The 61-year-old's condition deteriorates faster than the trajectory suggested. He dies before the second attending arrives. The team managing him followed every protocol. No one made a mistake. You write 2 operative notes that night. One documents a successful repair. One documents a death. Nobody asks you to formally justify the triage decision. It falls within the documented framework of a legitimate emergency call. No formal review is required. Nobody asks. You don't volunteer. The older man is dead because of a choice you made. The child is alive because of the same choice. You hold both of those facts in the same night, and then you go check on the boy in the pediatric unit before you leave the building. He is asleep. His chest rises and falls on its own. Operating days run 10 to 12 hours. You fit the pain into the schedule the way you fit everything that cannot be fixed right now. Your child is 6 years old. They know you are a cardiac surgeon the way they know the capital of France. A fact about the world, not a fact about you. Year 1 as an attending ends. You are 36. Debt, $255,000. One letter in a file with no formal response. One triage decision in no formal review. 2 operative notes. 1 alive, 1 dead. Rank 7, the board-eligible thoracic surgeon. The chest you are about to open has been opened before. The scan shows dense scar tissue throughout, adhesions, the body's own repair material binding the surface of the heart to the underside of the breastbone. The heart may be directly behind the bone. One wrong pass of the saw before the heart is connected to the bypass machine, and the case ends before it begins. This is called a reduced sternotomy. It is the operation that separates the surgeons who take the hard cases from the surgeons who refer them. The patient is 64 years old. This is his second operation on the same chest. You have reviewed the scan 3 times. You go in. Entry takes 40 minutes. You work centimeter by centimeter, using scissors and controlled electrical current to develop the plane between the bone and the heart's surface. You feel your way as much as you see it. The heart is stuck to the surrounding tissue in 2 places. You take it down carefully. No injury. You establish bypass. The pump runs for 2 hours and 50 minutes. The repair is completed. The patient is breathing on his own the following morning. The certification process. After completing training, cardiac surgeons enter a window, roughly 2 years, during which they must submit their operative records, pass a written exam, and complete an oral examination to receive full board certification from the American Board of Thoracic Surgery, the national certifying body for this specialty. The written exam is a full day of clinical scenarios. You pass. The oral exam places you in a room with 2 senior surgeons who present emergencies and require you to manage them out loud, in real time, without any reference material. One examiner is methodical, the other interrupts. You pass both on the first attempt. Rank 8, the board-certified thoracic surgeon. The certification changes what the hospital's credentialing committee will officially authorize you to do. More complex operations, higher risk cases. It does not change what happens in the operating room. You are the same surgeon on the day after certification as the day before. What changes is that the program now calls you when the case is hard. 3 months later, reviewing operative notes from junior surgeons in your group, you find something. A bypass case from 2 weeks prior. The surgeon used the forearm artery as the bypass vessel. The preoperative circulation test, the same borderline test result you flagged 4 years ago, is documented in the chart. The result was borderline. The surgeon proceeded without raising it. Post-operative notes mention mild numbness in 2 fingers of the donor hand, attributed to how the arm was positioned during the operation. You recognize the sequence. Not identical to what happened in your 4th year. Close enough. You have 3 options. Bring it to the formal complication review conference, which creates a permanent record. Speak to the surgeon privately. Document it and monitor. You choose the private conversation. You explain the circulation test, what borderline actually means, why it has to be raised before the incision, what to watch for in the hand afterward. You file nothing. The finger symptoms resolve 2 weeks later. You don't know if that was the right call. You know it was the one you made. That same month, your parent is admitted to a hospital 400 miles away. Serious. A heart rhythm problem with a secondary lung complication, managed in the ICU. You call the treating team that evening and ask the right questions. Your parent is discharged 11 days later. You visit the following weekend, on a Sunday, between 2 scheduled cases. After the long redo case, something changed in your left hand. The 2 smallest fingers go numb intermittently, for minutes at a time. You note it. You attribute it to the position you held for nearly 6 hours, arms forward, neck bent. You schedule nothing. You tell no one. Debt, $175,000. Age 39. Board certified. One private conversation not in any formal record. Your parent is home. Your child is 9 and has started asking what you actually do all day. You give accurate answers. They listen, then go back to what they were doing. The program becomes yours. Rank 9, the surgeon-in-chief. The appointment is given, not automatic. Not earned by accumulation alone. Someone with the authority to make the decision decided you were the person. You are 48 years old. You have performed approximately 400 cardiac operations. Now you run the program. The first call you receive as surgeon-in-chief comes at 2:10 a.m. An operating surgeon has done everything correctly and the patient is still dying. Without something more, the patient will not survive the night. You are called because this is what the title means. You are the last option. You go in. 40 minutes of mechanical support, a pump temporarily taking over the heart's work, combined with medications and careful management of how the heart is asked to recover. The heart finds a rhythm it can maintain. The patient goes to the recovery unit alive. You have 2 cases like this in your first month. Both survive the operating room. One survives to discharge. This is considered a good month, the full accounting of what you control. Which surgeons get, which cases, what high-risk operations this hospital accepts, who trains here and at what pace, and which cases land on your table when the operating surgeon has run out of options. You still operate 3 days a week. It is the only part of the job that feels entirely like itself. In your second year, you raise the insurance disparity formally. Data. A decade of your program's own outcomes. Procedures stratified by insurance status, documented and persistent. You bring it to the committee with the standing to act on it. The committee listens. A working group is formed. 2 years later, a report. The report recommends further study. You read it. You file it. That is the same verb you used when you were 24 years old and had no standing to do anything else. Same gesture. Different room. 24 years later. The accounting, everything you have carried. The Medicaid patient you noticed as a student and had no rank to question. The 72-year-old with a 19% mortality estimate who was operated on and died. The vein branch you tore and clipped and said nothing about. The borderline circulation test you flagged and watched get overruled and the 2 fingers that went numb. The woman with dementia whose family sent a letter that said the surgery caused more harm than it prevented. The 61-year-old man who died while you were saving the child. The junior surgeon you spoke to privately and chose not to formally report. The spinal imaging you haven't disclosed. The 90-some Sundays you were not home. Your parents' last 3 months. The school performance on a phone screen. None of these produced formal findings. None of them disappeared. Then the spine imaging comes back. Cervical stenosis, narrowing in the vertebrae of the neck, compressing the nerve pathways that run down into the arms and hands. The spine surgeon is direct. Continued high-volume operating carries a meaningful risk of permanent nerve damage. Not a certainty. A risk with a number attached. The number is not small. You reduce your operative schedule by 1 day per week. You are not ready to examine what it means that you made that choice, so you don't. Your parent died 14 months ago. You attended the funeral on a Friday. You operated the following Monday. Your child is 17 now and asked you once directly, no anger in it, what this has all actually been for. You gave the honest answer. It took longer to say than you expected. Your child listened to the whole thing and nodded once and went back to whatever they were doing. They haven't asked again. You think about that nod sometimes. Then the letter arrives on an ordinary Tuesday. The boy whose aortic tear you repaired on the night the 61-year-old man died is now 25. His letter is short. He works in a cardiac unit. He wanted you to know. The only thing in 29 years of practice you have not filed. A third-year medical student has been assigned to the cardiac service for her first week. She arrives at 5:45 a.m. Someone hands her a suction tip and tells her not to touch anything. The chest is open. The bypass machine is running. The heart is still. Your hands are moving. A new valve being seated, each stitch placed with the same precision you have been building for 29 years. 14 minutes to finish the connection. The student watches on the monitor above the table. She sees the heart stopped. She sees the new valve tested. She has no idea what it costs. She will learn. Everyone does.